Clients enter clinical treatment taking a complex array of substances and medications. Chemical dependency counselors do not prescribe or dispense these drugs. Yet, a client's success heavily depends on how well counseling and medical management are integrated. This creates a distinct professional boundary. The counselor operates as an educated coordinator and a direct support system for the medical plan, without ever crossing into the practice of medicine. To understand that medical plan, we must first look at how these substances interact with the brain. This is an abstract visualization of a neural receptor. An agonist is a substance, like heroin or methadone, that fully locks into this receptor and activates it, producing a physiological effect. Conversely, an antagonist physically blocks that receptor. It occupies the space without activating the signal, completely repelling the agonists so they cannot produce their intended effect. A partial agonist occupies the receptor and activates it, but only up to a point. It produces a limited effect with a strict ceiling, mitigating the extreme highs and respiratory risks associated with full agonists. How long these interactions last depends on a drug's half-life, the time required for half the substance to clear the body. Over time, the body adapts. It develops tolerance, requiring more of the drug to achieve the same effect, and physical dependence, which triggers withdrawal when the substance is removed. Mastering these mechanical concepts equips the counselor to follow complex clinical discussions. It allows them to translate a physician's medical plan into clear, accurate, and stigma-reducing education for the client. Different drug classes produce entirely distinct physiological risks. Central nervous system depressants, which include alcohol, benzodiazepines, and barbiturates, work by heavily slowing down brain activity, producing sedation and impaired coordination. Because the brain has adapted to this severe suppression, removing a depressant throws the nervous system into overdrive. Withdrawal from alcohol and benzodiazepines can cause seizures and delirium tremens. It is a strictly medical emergency that can be fatal without supervised detoxification. Opioids, including fentanyl and prescription pain medications, relieve pain while producing euphoria and sedation. Their immediate lethal threat comes from overdose, which aggressively suppresses the respiratory system until breathing stops entirely. This chart tracks the steep drop in a user's physiological tolerance after a period of abstinence. When that reduced tolerance intersects with a previously typical dose, the user enters an extreme overdose risk zone. While opioid withdrawal is intensely uncomfortable, the subsequent loss of tolerance is what drives post-treatment overdose fatalities. Stimulants like cocaine and methamphetamine speed up the nervous system. Rather than a medically dangerous physical withdrawal, halting stimulant use results in a severe psychological crash. The client experiences intense fatigue, deep depression, and overwhelming craving. Other classes present their own clinical challenges. Cannabis use disorder brings cognitive effects and sleep disturbance. Hallucinogens severely alter perception. Inhalants introduce high systemic toxicity. And nicotine remains a highly addictive driver of preventable death that requires attention during treatment. The exact pharmacological profile of a substance dictates the treatment response. A client's presentation immediately determines whether they need standard psychosocial support or an immediate transfer to an emergency medical facility. For opioid use disorder, comprehensive behavioral therapy is strongly supported by highly researched pharmacological interventions. Medications for opioid use disorder drastically lower illicit use, retain clients in treatment facilities, and measurably reduce overdose fatalities. Methadone is a full opioid agonist. When administered at a stable, clinically monitored daily dose, it prevents withdrawal and dampens craving without triggering the intense euphoric highs and lows of illicit drug use. Buprenorphine functions as a partial agonist with a built-in ceiling effect, significantly lowering the risk of respiratory suppression. Because it can actively displace other opioids on the receptors, the medical team must carefully time the induction to avoid precipitating immediate, severe withdrawal. Naltrexone is an opioid antagonist. Often administered as a monthly extended-release injection, it completely blocks the effects of opioids. However, because it is a strict blocking agent, the client must be fully detoxified prior to their first dose. Naloxone, widely known as Narcan, is also an antagonist, but it is not a daily treatment medication. It is an emergency, rapid-acting reversal tool used strictly to stop an active opioid overdose. Counselors must actively support clients and their families in obtaining and learning how to use it. Alcohol use disorder has its own distinct pharmacological toolkit. Naltrexone is used to reduce the rewarding effects of alcohol. Acamprosate helps stabilize the brain chemistry disrupted by chronic drinking. Disulfiram acts as a strict behavioral deterrent, causing a severe, unpleasant physical reaction if alcohol is consumed. These are highly specific, stabilizing interventions. At stable clinical doses, these medications normalize brain function. They do not produce intoxication. They suppress physiological chaos so the client can effectively engage in the cognitive work of counseling. Many clients enter recovery dealing with chronic, severe pain. This physical reality presents a constant threat to their stability. The clinical tension is unavoidable. Leaving pain untreated acts as a direct, proven driver for relapse. However, treating that pain with opioid medications poses a hazardous risk to any patient with a history of opioid use disorder. Best practices resolve this tension by prioritizing alternatives. Medical teams focus heavily on non-opioid medications and non-pharmacological interventions, leaning on physical therapy, mindfulness, and behavioral pain management. Executing this strategy requires continuous, precise communication. The addiction treatment team, the client's primary prescriber, and specialized pain management clinics must operate with full awareness of the client's recovery status. The counselor's responsibility is highly proactive. They reinforce non-pharmacological coping skills during sessions and help the client advocate clearly for recovery-informed care during their external medical appointments. But the boundary remains absolute. Under no circumstances does a counselor advise a client to start, alter, or refuse a physician's medication. Treating chronic pain during recovery rarely results in a completely pain-free state. Instead, it requires the entire care team to safely navigate the narrow space between leaving relapse triggers untreated and prescribing hazardous medications. Approximately half of individuals with a substance use disorder will also experience a mental health disorder. Historically, clinical systems attempted to treat these sequentially, forcing clients to resolve their addiction before addressing their mental health, which caused massive care failures. Current evidence demands an integrated approach. Both the substance use disorder and the mental health disorder must be evaluated and treated concurrently as primary conditions. This visual split represents clinical mimicry. The physiological effects of active substance intoxication or withdrawal can perfectly imitate the symptoms of an independent psychiatric condition, manifesting as acute anxiety, deep depression, or even active psychosis. Because of this mimicry, assessment must be continuous. The clinical team must evaluate the client over an extended timeline, particularly during periods of strict abstinence, to determine if the symptoms resolve without the substance or persist as an independent psychiatric disorder. If a counselor fails to recognize these physiological or psychiatric symptoms, they risk completely misinterpreting the client's actions. Real medical distress is frequently misidentified as simple behavioral defiance. The flat, unresponsive affect caused by clinical depression can be mistaken for a lack of motivation. The hypervigilance of PTSD may look like deliberate avoidance, and the impulsivity of ADHD is easily labeled as a refusal to follow rules. Furthermore, a client's readiness to change is rarely uniform, strict principles for co-occurring disorders. The core requirement is interdisciplinary communication, ensuring the client receives unified, medically sound messaging from every provider they encounter. Mislabeling a genuine psychiatric symptom or physical withdrawal as a personal flaw fractures the therapeutic alliance. Diagnostic patience allows the counselor to support the client without accidentally punishing them for their illness. Navigating complex medications, chronic pain, and overlapping psychological symptoms requires the counselor to know the exact limits of their license. The definitive through line of an addiction counselor's practice is understanding the firm boundary between supporting a medical plan and practicing medicine. Within their scope, counselors have clear affirmative duties. They educate clients accurately about their prescriptions, support their daily adherence, work to reduce social stigma, and carefully document warning signs or concerning side effects. Outside their scope are absolute prohibitions. A counselor cannot diagnose a medical or psychiatric condition, they cannot recommend starting a specific drug, and they cannot advise any adjustments to a dosage. These phrases outline the sharp contrast. Telling a client, "You probably don't need that medication anymore," directly violates the scope of practice. Responding with, Let's make sure your prescriber knows about that side effect. Successfully keeps the counselor within their proper clinical lane. A counselor's deep pharmacological literacy is precisely what makes them valuable. By understanding drug mechanisms and tracking symptoms, they supply the prescribing physician with critical behavioral data the doctor would otherwise never see. Refusing to prescribe or alter medications is not about limiting the counselor's influence. It is a necessary mechanism to protect the client from receiving conflicting, potentially dangerous medical advice. When the clinical boundary is functioning properly, the environment stabilizes. The client relies on the physician for chemistry and the counselor for behavioral strategy. Rigid professional boundaries act as the structural framework for the integrated care model. Knowing exactly where authority ends is what makes holistic, life-saving recovery possible.